For the sixth case, normally it will be conducted by Dr. Salwa, but unfortunately Dr. Salwa, she is sick today. Instead of her, Dr. Hiba Sharif, she will present her case. Thank you. Is Dr. Hiba,
They are actually two cases. Two cases, different presentations and same diagnosis. First case is Indian female patient, 44 years old, homemade, presented with multiple itchy lesions over her upper limbs for a year ago. On taking history, no diabetes mellitus or other medical disease, no history of animals contact, no history of any treatment except some salts. General examination, generally well, no enlarging lymph nodes. Skin examination, hyperpigmented vivacious papules and nodules arranged in annular plaques 5 to 6 centimeters in diameter, distributed bilaterally over the arm. So in the case, what do you think about differential diagnosis? Our differential diagnosis is annular lichen planus, annular psoriasis, cutaneous lupus, especially subacute cutaneous LE, tinea corporis, atypical mycobacterial infection, cutaneous TB, tuberculoid leprosy, mycosis fungoides, granuloma annular, discoid eczema, secondary syphilis, and Lyme disease. Second case is a Syrian housewife, female patient, 34 years old, presented with large circular itchy lesions all over the body, 4 months ago. History, no diabetes mellitus or other medical disease, no history of animal contact, history of different topical agents in the last advances. General examination, generally well, no enlarged lymph node. Skin examination, annular erythematous skinny patches and plaques ranging from 2 cm to 20 cm in diameter, distributed bilaterally and symmetrically all over the body. This is the case. Differential diagnosis. Tinea purpura, annular psoriasis, discoid eczema, gyrate erythema, secondary syphilis, Lyme disease, mycosis fungoides, and cutaneous TB, and subacute cutaneous lupus. Investigations, CBC, liver function tests, and renal functions, all within normal. VDRL and HIV were negative. KOH was done for both patients, was positive, showing segmented hyphae of dermatophytes. Diagnosis, they are cases of tinea purpuris. Treatment, itraconazole capsule 200 mg once daily for 1 month, terbinafine cream, ketoconazole shot. This is the first case after 1 month. According to Dr. Salwa, the patient was very happy because the itching, there is dramatic relief of itching, also margins severe, just post-inflammatory hyperpigmentation. And this is the second case. Tinea purpuris. It's a common fungal infection, mimics many other annular lesions. Dermatophytes causing tinea purpuris belonging to Trichophyton, Echidnophyton, and Microsporum genera. The most common one is Trichophyton proper. It is a superficial fungal infection of the skin, can affect any part of the body, presents as solitary circular patch, red patch with a raised scaly active edge. Lesion spreads out from the center, forming a ring shape with central clearing and peripheral scaly red papular or pustular rim. And this is the ring shape, so it is called ringworm. H is common. Multiple lesions can develop which may coalesce to form a polycyclic pattern. Distribution is asymmetrical. In the typical circumstances, the diagnosis of superficial dermatophyte infections is straightforward, with no need for extensive or even simple laboratory investigations. Many published literatures highlighted on atypical presentation of superficial dermatophyte infections. These were easily missed and wrongly diagnosed. Dobra and Narang in 2017 reported cases with unusual presentation of dermatophytosis in Indian peoples, which are termed as atypical tinea. Atypical tinea can be seen even in immunocompetent patients who aren't using any topical or systemic medication such as corticosteroids. Patients with atypical tinea are presenting with widespread atypical, extremely symptomatic lesions require prolonged duration of therapy. Subsequently suffer from frequent relapses within few days to weeks of stopping treatment. Newly described genotype within the species Tinea mentacrophyes was identified by sequencing of the genetic rDNA of the fungus. This is the main positive agent of current epidemic of atypical chronic recalcitrant dermatophytosis in India. Transmission of this Indian genotype to other countries was reported due to globalization. This strain is resistant to terbinafine and partially resistant against itraconazole and voriconazole due to squalene epoxidase gene mutation. Multiple atypical clinical varieties that mimic other skin diseases have been recorded. Eczematus dermatitis-like, psoriasis-like, impetigo-like, seborrheic dermatitis-like, erythema multiforme-like, pyoderma gangrenosum-like, lupus erythematosus-like, lichen planus-like, dermatitis herpetiformis-like, herpes-like, and polymorphous-like eruption-like. Host factors. All people don't have equal susceptibility to fungal infection. There are familial and genetic predispositions mediated by specific defects in innate and adaptive immunity. Host factors include low defensin beta-4, underlying diseases such as diabetes mellitus lymphomas and immunocompromised conditions, excess weighting, palate progress, old age, dealing with animals, contaminated soil, or exposure to flies. Currently, the end view is that cell-mediated immune response is responsible for control of dermatophyte. Causes of treatment resistance, misdiagnosis, neglection, non-compliance, using corticosteroids, wrong treatment regimen, either dose or duration, immunocompromised patient, untreated site, genetic alteration of fungi, and biofilm genes. Our message: tinea corporis, if neglected, may have significant negative social, psychological, and occupational health effects. It can compromise the quality of life significantly. The atypical clinical presentation of cutaneous fungal infection might be a new dilemma that can be added to many great imitator skin diseases. The clinician should consider dermatophyte infection and non-responding and recalcitrant lesions of common skin diseases. And thank you.